Good morning.
How are you?
We're good. How are you?
All right, thank you. All right. 1 second. Okay. All righty. I think we have pretty much see Maya and Molly. We have Tulsi. Do we know if Tarek is joining this morning, or is he on vacation?
He's in Casablanca. Yeah, he's not joining.
Oh, okay, sounds interesting. Okay, so let's move forward. Okay, so continuing on our drug review, go over class 1A agents this morning. And these include quinidine, procainamide, and disopyramide. These are the three main class 1A agents that we talk about. So these agents all block rapid sodium channels, slowing the upstroke of the action potential and potassium channel, and they prolong the duration of the action potential and prolong refractoriness. So this is the impact on the action potential that, as in general, one would see from this agent. So let's go through each one separately. So quinidine, which is very rarely prescribed in the present era, is absorbed 80 to 90% from the GI tract. It's eliminated via the liver. It has a half-life of about 5 to 8 hours. And it is, as the case with most 1A agents, both a sodium channel blocking agent as well as a potassium channel blocking agent. It's a fairly potent arrhythmia medicine. Hemodynamically, it actually blocks alpha adrenergic receptors, resulting in peripheral vasodilation, as well as reflex tachycardia. And it also has a vagolytic effect, so it may improve AV conduction in patients. And so the traditional or classic recommendation when prescribing quinidine, particularly for SVTs or atrial arrhythmias, is to add an AV nodal blocking agent when treating any atrial arrhythmia. And it is not known to have any significant negative inotropic effects. So, quinidine used to be used for both atrial and ventricular arrhythmias. I think in the present era, we'll go over why we don't use it so much anymore, but it can be used for accessory pathway mediated tachycardia, such as orthodromic reentrant tachycardia, can be used for AVNRT. Probably in the present era, the most common time it's still used and why it probably hasn't been taken off the market is for the treatment of Brugada syndrome. Patients with Brugada can have lots of episodes there. Most of them, thankfully, do not have very frequent episodes of arrhythmia, both VT and SVT. But for those who have a lot of tachycardia, lots of shocks from their defibrillator, quinidine has been demonstrated to reduce the incidence of shocks and just tachycardias in general. So rarely you will see a Brugada patient still who is taking quinidine. Side effects, the side effect profile is the reason we don't really see this agent used very often, except for Brugada syndrome, because almost half of people who take quinidine have these side effects, and these include diarrhea. They can be proarrhythmic, and then so-called synchonism, which is a combination of tinnitus, visual blurriness, and hearing disturbances. So a lot of neurological symptoms related to its use. So if that's one of the reasons we don't see quinidine used very commonly any longer, even though it is a relatively good antiarrhythmic agent. It potentiates the effect of warfarin, so you have to adjust your warfarin levels when you're taking quinidine. It increases digoxin levels. So one has to lower the digoxin dose when you have somebody who's on that agent. Although again, in the present era, it's unusual that we would be treating any primary arrhythmias with the exception of Brugada patients with quinidine. Levels of quinidine are lowered when given the following agents: phenobarbital, rifampin, and phenytoin. Seems to me like it's probably has something to do with liver metabolism, maybe the cytochrome P450. I'm not actually sure, but these agents will lower your levels of quinidine. So you have to raise your dose. And then finally, levels are higher when giving amiodarone concomitantly. So in the old days, and this precedes my time as a physician, if one were giving quinidine to somebody and amiodarone, obviously someone with a very bad arrhythmia, the levels would be higher and one had to adjust downward the dose of quinidine for that. Okay, I think for right now, the most important thing is to remember that it has some indication for Brugada patients. Okay, procainamide. Procainamide is absorbed 70 to 90% from the GI tract, and it is metabolized in the liver to a substance called NAPA, which is actually a class 3 metabolite, and NAPA is excreted by the kidneys. So one needs both liver and kidney function in order to metabolize procainamide. And it's important to remember that it is, although it is a 1A medication, and that's its formal designation, it also has class 3 effects. Dr. Ed Walsh in Boston Children's always used to make a very important point about it also being a class 3 agent. Its half-life is relatively short at 3 to 5 hours. And again, it's both the sodium and potassium channel blocker because of its metabolite NAPA. Hemodynamic effects, it blocks alpha adrenergic receptors, resulting in peripheral vasodilation and reflex tachycardia. And so it's not uncommon when giving procainamide, particularly when you're starting it, to get hypotension. So the most important thing to remember is to slow the infusion down. And I think we've talked about this agent in the past. You know, if you will go over dosing, but if you look at the most of the dosing, it'll say that the loading dose is between 10 to 15 milligrams per kilo. That's true that most patients do need that much, but probably it makes the most sense to give 5 per kilo per load and then treat per response. In other words, give 5 per kilo, maybe over 30 to 60 minutes, observe, give another 5 per kilo, give another 5 per kilo as needed. Always one wants to have volume available when giving procainamide because of the hypotension. But importantly, it is not a direct negative inotrope except when it's toxic. And in fact, of all the IV antiarrhythmic agents, with the exception of sotalol, which was not compared in the study that I'm referencing to you now, procainamide has the lowest negative inotropy. So it's actually a very good medicine in post-op patients who already have suppressed function related to maybe a big operation and a long bypass run. Yes, it can cause hypertension, but it's not due to a negative inotropy, and it can be managed if the dose is given slowly enough and if there is volume and other agents to reverse it. And it doesn't cause, for example, the cardiovascular collapse that can rarely be seen as an idiosyncratic reaction to amiodarone. It's really can be used for virtually any typical arrhythmia that we see. It can be used for the management of people who have atrial reentry, such as intraatrial reentrant tachycardia or other forms of atrial flutter, where it prolongs the cycle length of tachycardia and it may terminate it. It's extremely good for the treatment of orthodromic reentrant tachycardia because it has it has effects on all the atrial and myocardial muscle, but it has particular effects on accessory pathway conduction, making it a very good acute agent in someone who's difficult to control. And it can be used very effectively for the treatment of ventricular tachycardia. And so as an acute agent for VT, particularly if it's not VT in the setting of long QT syndrome, procainamide is a very good agent for that as well. And we talk about this quite frequently. If somebody has atrial arrhythmias, such as atrial fibrillation with rapid conduction through an accessory pathway, as is seen in the setting of Wolff-Parkinson-White syndrome. Giving procainamide will prolong the effective refractory period of the pathway and slow conduction. So, if you have a patient with rapidly conducted AFib, a correct answer to how to manage that would be the administration of procainamide. Normally, we would just cardiovert such a patient, but if there were inability to do that, or if the patient were stable and you had procainamide readily available, it would not be unreasonable to give IV procainamide to slow conduction. We've already spoken about the side effect, most common side effect, which is hypotension with IV infusion. And again, if it's given in smaller boluses and if the infusion is started slowly, it's uncommon to have significant hypotension. When it is given orally, it can cause nausea and vomiting in about a quarter of patients. And it can cause agranulocytosis seen in the first 3 months in a small percentage of patients. And this last point about lupus-like syndrome being seen in 20% is more common the longer the therapy is administered, and the symptoms will usually resolve within a few weeks of discontinuation of the medication. But it really does masquerade with all of the symptoms of lupus, including the malar rash and other things that you can see in lupus. And this used to be a very important question that people would ask cardiologists or in your boards. It's not as important today because it's very uncommon that we're giving people chronic oral procainamide. And the main reason we don't give it is because it comes as first of all, because of this very serious concern of this lupus-like syndrome for long-term use of it, but also because it only comes, it has a short half-life, as we've just discovered, and it has to be administered orally very frequently. The long-acting version is given twice a day, and it comes as a very large tablet, like something like 1,000 milligrams or more. And so basically, you have to be an adult-sized person to take procainamide. And I think in the present era, there are enough other agents that don't carry these side effects that it would be uncommon in the present era for somebody to be on chronic oral procainamide. Drug levels will be increased if amiodarone or trimethoprim is given with procainamide, so one needs to lower proc dosing with that. And then finally, drug levels are decreased with alcohol consumption. So if somebody is drinking alcohol, their procainamide levels will be lower, potentially enhancing the risk for arrhythmia. The last of the so-called 1A agents is disopyramide, which honestly is very dissimilar chemically to quinidine and procainamide. It is a sodium channel blocking agent, but it's just for purposes of categorization. It's put in the same category, the 1A agents, as quinidine and procainamide, but mostly because it has a similar electrophysiologic effect. It is almost never used in the present era. Probably the most common indication for it is in the treatment of people with hypertrophic cardiomyopathy. It has very important negative inotropy. So probably of all the agents that exist, disopyramide has the most negative inotropy. And actually, more commonly in the past, it was used as an agent for people who had HCM and had a lot of outflow obstruction. So if somebody had like 100 millimeter gradient, you would give them disopyramide, and it would not be uncommon that the gradient would fall quite substantially on this agent. And every once in a while, you will see a patient, an older patient who has been on disopyramide for many, many years with good results as a result of it. So it does still have a small indication in medicine, but it isn't really used very commonly for almost anything else. It also has a lot of side effects, particularly anticholinergic effect. About 40% of patients can have dry mouth, eyes, and throat, not a very nice side effect. And it can precipitate closed angle glaucoma. So basically, my suspicion is, since most of you are very young, it's unlikely you're going to see very many patients on disopyramide. It is possible, like in the case of Brugada syndrome and quinidine, there may be some new indication for it in the future, but I'd be surprised if all of you ever see a patient who is on this agent. But every once in a while, you'll meet like an ACHD patient who was started on this in like 1979 and has had good results with it and has remained on it all that time. Okay. All right. Any questions about drugs? These drugs, the 1A agents today? You guys finding the review of the agents to be useful? It's a waste of time. What do you think?
It's fantastic.
I think it's useful.
Okay. Very good. All right, we'll move on then to a couple of unknowns for the day. All right, so this is a remote pacemaker / ICD download that Josie O'Toole was kind enough to send to me. As you know, every single day, Monday through Friday, Josie reviews all of the downloads from all of our device patients and then prints them and marks them if there are issues that she's concerned about to remind me to pay more attention because she knows I am inattentive sometimes. And so I very much appreciate that. So this is a remote monitor download from a patient who has a pacemaker. And there are some arrows that I have drawn there. And I guess my question is, what is actually happening here and how would you reprogram this pacemaker to address it? Let me just explain that in most of these remote monitors, the first page or the first thing that is in the report is usually sometimes it's called the presenting electrogram. In Medtronic's case, I guess it's called the current electrogram. So essentially what they're doing is giving us a little sample of the patient's rhythm as described or demonstrated by the electrograms of the device. So we'll just go through these so everybody understands what we're looking at here. So we see here electrogram number 1 is the atrial electrogram, so tip to ring. These are the 2 electrodes on the end of a bipolar pacing lead. One is called the tip and the other the ring being the ground, the tip being the pacing portion. And so this is the atrial electrogram. We see it's a very nice, clean one with just a nice sharp A, not so much V, a little bit of a far field V here. And we've talked in the past that atrial pacing leads will sometimes have a far field ventricular electrogram because the most common location we put pacing electrodes in the atrium is in the appendage, which hangs over the ventricle and can sometimes record far field V. This is the electrogram number 2 from the can to the RV coil. So this is an electrogram between the actual device. The device is sometimes referred to in pacing lingo as the can. And the coil is the shocking electrode that is further up in the pacing lead for a defibrillator lead. So this should represent a ventricular electrogram. Then there is the third electrogram is RV tip to RV ring. And so this is similar or analogous to the atrial electrogram in that this is the recording that is made between the distal 2 electrodes on the lead. Medtronic's pacing leads are what are called true bipolar leads, meaning that there is a tip and a ring at the very end of the lead. Some leads will use the coil as the ring and just have a pacing electrode at the end, for example, Boston Scientific. And when they have that, they call that an integrated lead, where they're integrating the coil into the sensing and pacing of the lead device. Theoretically speaking, having a tip and a ring on the actual pacing lead separate from the coil should make it a little better in terms of sensing, although I'm sure if Boston Scientific were listening to this, they would say that is not true, but that at least is the theoretical benefit. And then finally, this is an electrogram between the can or the device and the SVC. So this patient's lead has 2 coils, has a distal coil, which all defibrillator leads have, but also has a coil that is a more proximal in the superior vena cava. So when you have 2 coils on a defibrillator lead, the hope would be that the defibrillation threshold will be lower because you're delivering the energy over a wider range. Generally speaking, that has not proven to be a substantial benefit over a single coil. And can you think of why it would be bad to have another coil more proximally in the SVC? Let me see, Sergey, why would you maybe not? So the advantage of an extra coil is potentially the device may have a lower defibrillation threshold, meaning a little better at being able to defibrillate people, but there is a major disadvantage to another coil. Can you think of one? Why would you not want another coil?
Trying to think why I would not want another coil. I'm not sure, Dr. Pass.
Okay, because it's not obviously intuitive, so I'm not surprised. Does anybody have any thoughts on why having another coil might not be a great idea? Some of you who've been in the cath lab when we put defibrillators in may have noticed that both Dr. Love and I virtually never put leads in that have two coils, right? Almost always it's just a distal coil. The reason is because it is harder to extract a lead that has two coils. The coil tends to fibrose more than a standard lead and gets itself attached to the SVC and the innominate vein, which is where most of the really bad, dangerous things happen when you're doing an extraction. The vein can tear as a result. The other reason that we don't love putting in leads that have an SVC coil is that our patients are still growing to some degree. And so you may put the lead in and the coil may be in a really nice location to potentially enhance defibrillation. But with growth, it may end up in a location that is not as useful or helpful. And so based on the fact that defibrillation thresholds are really not very profoundly improved by the presence of an SVC coil, as well as all the problems I've just described, generally speaking, we do not put that in. Occasionally, if we have someone who we are anticipating will have a very high defibrillation threshold, for example, maybe somebody who has who's very, very large or has a very large heart with very, very bad function, it might not be an unreasonable thing to consider. But honestly, I don't think I put one in with two coils in probably about 5 or 10 years. But that may just reflect that we're not as busy as some programs, but I would be surprised if most programs are putting those in at this time. Okay, so now we know what the electrograms are, and you can see here, there is also a marker channel on the bottom where it's telling us, the patient is A-paced, V-sensed. And we see that it's at cycle length 1,000. So what does that mean about the lower rate limit of the pacemaker? Molly, if it's pacing at cycle length 1,000, what is the rate that the person who programmed this device set as the lower rate for the pacemaker?
It would be at 60, with 60,000 divided by 1,000.
That's exactly right. Thank you. Okay, good job. So we're pacing at 1,000 millisecond cycle length. And what do you see that's happening here? So why don't I ask Dr. David Barris, back from a prolonged vacation? Well deserved.
Good to be back. So we're looking here at our tracings. We're noticing that we're A-paced and V-sensed, and then the spaces where our arrows are, we're A-paced, and then we don't get a ventricular depolarization.
Mm-hmm.
And we also notice that the A to V interval is getting longer, and then we get that dropped beat. So we're getting some sort of, we're getting Wenckebach, second degree heart block. And the way that I would reprogram the pacemaker is maybe using MVP pacing, minimal ventricular pacing, where the pacemaker will then, if it has 2 dropped beats, will then switch to DDD mode. But then if it has good AV conduction, it'll go back to AI pacing.
That's exactly right. Very, very good answer, David. That is what we would normally do. So this tracing sort of demonstrates one of the problems associated with pacemakers in people who have preserved conduction of some sort, but not normal conduction. So if somebody's in complete heart block, the answer is pretty easy. You have to A-pace and you have to V-pace the patient. But as David explained, there is this modality called minimized ventricular pacing or minimalization of ventricular pacing, where the pacemaker is programmed in an AAI mode, pacing only the atrium, allowing for patient conduction. But if it sees non-conducted beats more than one, it will revert to DDD pacing, so that the patient has an adequate ventricular rate. And then after a period of time, we'll go back to AAI if it senses that there is conduction. In this case, I contacted, it's actually a patient of Dr. Love's, and I contacted him, and what he explained to me was that this patient, when he is ventricular or she is ventricularly paced, hates the feeling of ventricular pacing. And so since the majority of the beats on a Zio or a Holter were conducted, the decision was made to leave the patient in an AAI mode and not turn on MVP pacing, even though it meant that the patient would have these pauses intermittently. The patient was felt so much better like this that they elected to do that. Now, can you think of any other negative impacts? So let's say we saw this, and actually I should say, let me take a step back. In my experience, almost every patient I have who has this feature turned on, once they start using it, they don't like the feeling. And the reason they don't like the feeling, I believe, is because they don't like the feeling of changing back and forth. The pacing feels abnormal because the heart is depolarizing differently. And so normally one has to make a decision, which is to either leave them like this, which I think in this case was very reasonable, since it is true that most of the beats are conducting, albeit in a Wenckebach or Mobitz 1 fashion. But you could also say that I don't like the idea that my patient's going to have, a 1 or 2 second pause, and I would rather just be certain that we had AV pacing. So for example, Josie and I saw a patient about 2 weeks ago, a Fontan patient who has always had that feature on her epicardial pacemaker, and was feeling ventricular pacing because the patient had a very similar kind of conduction, albeit a little bit worse. And so basically that patient was in DDD mode like 35% of the time, and was AAI 65% of the time. And she was very bothered by the feeling of ventricular pacing. Unlike this patient, though, the vast majority of the atrial events were not conducting. So in that case, we had to make the patient DDD with continuous V pacing because of the concern that there would be long pauses, because the conduction was much worse than this patient. And what I explained to that patient was that it was likely that after 2 or 3 weeks of V pacing all the time, they would feel that would become their norm, and they would feel okay like that. Now, any disadvantages though? So this was a Fontan patient, to switching them to DDD. So we make them feel better. It no longer feels like V pacing is abnormal to them. They get used to it. But can you think of any negative impacts in a Fontan patient to DDD pacing them as opposed to AAI pacing them? Anybody have any thoughts?
Well, there's battery issue.
Yeah, that's
Here.
true. Pacing the V basically will cut the battery length in half, probably. That's true. Any other negative impacts you think for V pacing? I see Molly has unmuted herself, as has Maya. Any thoughts on why V pacing in a Fontan patient might not be a great idea? Well, actually, there's actually a recent study that just came out like in the last 2 or 3 weeks, but it's not dissimilar from other studies on this topic, which basically show that when you V-pace Fontans, on average, they do much worse. Like they die much sooner. They just really degenerate pretty quickly. So needing to V-pace a single ventricle patient, although critical in some patients, is probably a bad sign that you are going to start doing worse. And that probably has to do with the dyssynchrony of pacing, right? We have in a single ventricle patient, we are already imposing on that ventricle to do a lot more than we normally would expect a single ventricle, a systemic right or left ventricle to do. Add to that the dyssynchrony of pacing, and it would not be shocking to imagine that these patients develop dysfunction or that the ventricular function will worsen. So I was really on the fence when we saw this patient, this other patient who was conducting less well than this patient. But in the end, I can't leave a patient with, Mobitz 2 block who is, having pauses all the time. And she clearly did not like having the switching back and forth, although it might have been better for her in that it would allow her to apace at least some of the time and allow some of her conduction to work. So okay, I'll do one more. So this was a tracing that was sent to me by a fellow who was dutifully reviewing tracings in the ICU. And the question I was asked was, is there VT here? Is this normal with artifact? What do I think? So I'm going to throw it up to you guys. Why don't we ask Maya what she thinks about this trace?
So,
I want to apologize for the slightly out of focus nature of this tracing, but this is actually real life. This is how I received the tracing. And so I am sharing it with you exactly the same way.
so I think it's artifact because I do see these QRS spikes that even though I don't really have calipers, it looks like they are kind of going at a consistent rate. I guess the confusing part is that the CVP tracing all of a sudden starts to get really kind of wonky at the same moment.
Yeah.
But I'm wondering if they're like doing chest PT or like, they're doing something with the baby at this moment.
Yes, a very nice analysis. I agree with you. I think this is artifact. I'm sorry, we don't have to really come up with a good artifact, a good caliper tool for PowerPoint. I probably could easily do that. I agree with you that if one took out calipers, you would probably see that the R to R interval here is the same, which is roughly 150 beats per minute. There is, however, I think, a PVC. I think this is a PVC. This beat is early relative to all the other ones. So I don't think it's VT. I agree with you that it is some sort of artifact, which is related to probably chest PT or something along those lines. But I do think there happens to be a PVC, which is of no real consequence just before this artifact thing, which sort of confuses it just a little bit. Could be a PAC with aberration. It's hard to tell because the baseline is so wavy here. And to her credit, Dr. Condon actually made this diagnosis, but I thought I would share it because I think it was a good observation on her part and an interesting tracing nonetheless. And then I guess we'll show one more. So this is a patient with an LVAD. And this is the telemetry. And do we think this is real? Not? Any thoughts on why this patient might have this, if it is in fact real, and do we need to treat this? So why don't I ask Dr. Grace Kong, who is here from the imaging world, a cameo appearance.
Hi, Dr. Pass.
How are you, Grace?
Good. So this looks real. You can also see that there's a PVC in the beginning of the tracing that looks similar morphology to the tachycardia. It looks like there's a ventricular focus that is the same. And you can also see in the arterial tracing that your blood pressure falls during the VT.
Right. So any thoughts on why this patient might have this?
Yeah, if it's an LVAD patient, it's likely that there was a incision done on the ventricle,
Mhm.
I guess. And also, I guess, if it was a cardiomyopathy patient, then they are at risk. Their ventricle myocardium isn't normal to begin with.
Right. So in this case, though, the most likely etiology of this is mechanical, right? From the cannula that is sitting in the apex of the left ventricle. Normally, we don't see it. Quite frankly, it's always amazed me we don't see it more often. I'm sure there's a reason for that, and we probably should ask Raghav that. Why we don't see VT more commonly, but this is just VT related to the cannula. Now, thankfully, because we're on an LVAD, we have good cardiac output, albeit not pulsatile during this episode. But there really is no treatment for this because it's mechanical, and thankfully it's very rare in this patient. I think we only saw it like twice the entire week, and it was very transient, as you see, just a matter of less than 2 or 3 seconds. All right, well, thank you very much. I hope you found this of some benefit. And now, last week we did angio as a makeup for the prior week. Does everybody want to do this week's one? Since this would be the normal week, we would do it. It would be on Thursday. Or
Sounds
we can,
great.
Sure.
okay. All right. So we'll do angios at 7:15 on Thursday morning. So hope everybody has a great day. I'll see you in a few minutes at sign out. Take care, everyone.
Thank you.